Welcome, everybody. Thank you for joining us this evening. As mentioned, the topic is ocular surface disease, glaucoma, and retinal disease when it comes to cataract surgery and considerations. Um, I just wanted to share that we have a great panel this evening. I am joined by two of my colleagues, Dr. Andrew Smith and Dr. Kapil Mishra. Dr. Smith is a glaucoma specialist. I'm a cornea specialist, and Dr. Mishra is a retina specialist. So we are going to utilize this evening's presentation to kind of help bring in our subspecialties and connect it to cataract surgery, and kind of go over the considerations and why it's important with these specific subspecialties. I am going to start out with just kind of giving a brief background on cataracts. So that way, when we get to the subspecialty topics, things kind of line up and make sense. So very briefly, we're going to go over what a cataract is, why it forms, how it impacts people specifically over the age of 65, how it can impact driving, and then I will close out with some corneal or ocular surface considerations when it comes to cataract surgery, and then pass on the baton to Dr. Smith, who will hit on glaucoma and how that ties into cataract surgery. Very briefly, just wanted to go over some anatomy here, just because we're going to be talking about different parts of the eye. So this is a cross section of the eye. And so when we're talking about ocular surface, we are including the conjunctiva, the cornea, which is the clear part of the front of the eye, which we basically can see into the anterior chamber, and the iris, which is the colored part of the eye. Behind the iris is the lens, and that's what forms the cataract. So when we're talking about the cornea and ocular surface, it's just this anterior part. Dr. Smith will be touching on, some of relation to glaucoma and the angle. And as we go more posteriorly into the eye, we have the jelly, which contains the eye, and then the macula and retina, kind of with Dr. Mishra's area of expertise, and then the optic nerve, which is what connects the eye to the brain. As will be discussed, that's one of the primary areas where damage can happen with glaucoma. So kind of tying this anatomy all together as we progress through our presentations. So common presentation in our clinics is I'm here to have my cataract removed. It's not a Cadillac, it's a cataract. So what is a cataract? A cataract is basically opacification or clouding of the natural crystalline lens in the eye. This process usually starts around the age of 40, and we have a way of measuring it. It's this functional lens index. This overall causes scattering of light that can impact our contrast, our ability to see, and 90% of the time it's related to aging. Other kind of considerations, people who have a lot of UV exposure, diabetes, had any sort of trauma to the eye, or take medications chronically like steroids can cause cataracts to form. Trying to demonstrate how a cataract affects our vision. Here on the left, you can see these two boys here with normal vision. In comparison, on the right, someone with cataracts. The contrast, the color, all of that is affected. And so this is a slow process. It's usually not something where people wake up one morning and notice this. It's over months to years this progression happens. And just kind of briefly trying to show there are different types of cataracts. A cataract like a posterior polar can affect the back center of the lens of the eye, or you can have a pretty obvious one, like a mature white cataract. Those of us that have dogs, who have an older dog, you've probably noticed as well, dogs do get mature cataracts. So it happens to even dogs as well. When it comes to symptoms, most common symptom is blurry vision, and glare, specifically at night, usually is the first symptom that patients will present. And then, the changing prescription in glasses, and then basically glasses not giving the good as vision as they used to. Not common in the United States, but ultimately, if the cataract is not addressed, it can lead to blindness. When it comes to those over the age of 65, 1 in 3 have some vision loss by 65, and this really affects our daily activities, specifically independence. When it comes to being able to, be freely mobile, there's a higher risk for example, fractures, and we'll get into driving as well, how that affects that. And losing these can lead to social isolation and depression. So taking care of cataracts is very important, not just for vision, but the many other things listed here. Tonight we are going to cover a lot of these, these top four causes of vision loss in our aging population, but just want to highlight cataracts are number three. Of all these other conditions listed here, cataracts is the only one where the vision loss is reversible. And so again, great when we get cataracts and we can bring back the vision, but also highlighting the importance that we detect and treat these other conditions when they form so we don't lose vision permanently. Um, Once again here, just highlighting that vision is very important when it comes to driving. Older adults have higher miles driven and higher risk for accidents related to vision. Those over 65, if they are in a car accident, have a higher risk for having a condition that is disabling or loss of life. And in many cases, patients are driving right up to their cataract surgery date. And if you don't believe me, this is actually one of my patients, a pre-op, not a post-op, who came in for their pre-op cataract measurements and missed the garage fence there and drove their car over. This is real. It does impact driving, and so important why we kind of address cataracts and also screen for other conditions when it comes for cataract surgery. Briefly here, just showing effects of contrast when it comes to cataracts and driving, kind of not being able to see this child, someone with a cataract when they're driving even in the daytime, and then debilitating halos when driving at night. Just kind of take home point here is that having cataract surgery actually decreases your risk for having a car crash by about 50%. So I don't know why insurance companies don't give us a discount when it comes to our patients who've had cataract surgery, but it's been published widely. Now, kind of bringing things here to the pre-op assessment, it is important to have a full, medical and surgical history evaluated to just determine if you're safe enough to have cataract surgery. Also, being able to review your past ocular history is important for us when we're doing a pre-op cataract assessment. And then really kind of the take-home point tonight is a detailed examination of the eyes, just trying to screen for other conditions that either need to be addressed before the cataract surgery or could affect your vision after cataract surgery. And we're going to hit many of those this evening. And also how that kind of comes into the picture is when it comes time to select a lens, if you do have any other condition, whether it's affecting the cornea, glaucoma, or retina, the lens choice could be impacted by that. So again, just making sure you're properly screened and evaluated for surgery. Um, when it comes to the surgery itself, 99% are done under topical anesthesia. So patients are awake, receiving a little bit of IV sedation. General anesthesia is not common unless there's some sort of a condition that we have to proceed with, general anesthesia. So for the most part, this is straightforward. Patients come in and they go home that same day. It is a quick procedure, takes about 15 minutes. And then patients don't need to come off their blood thinners for this procedure. That's a common question. So I am going to share a surgical video just to kind of highlight the steps of cataract surgery. This is just a few minutes long. If you're a little squeamish, you may want to look away from the screen, and then I'll let you know when it's done if you don't want to see. But just kind of trying to show this is a quick surgical procedure that is very safe. We make micro incisions there. This is anesthesia to basically numb the eye so that at this point the patient is no longer feeling anything that's going on in the eye. And then we inflate the eye with a jelly here, and it just keeps the eye from collapsing during the surgery. And then we make a small, just a little over 2 millimeters incision for our main. And then this is the dilated pupil here, and then the cataract is behind that. So we're going to make a small puncture in the capsule of the cataract, and then try our best to make a very circular opening here. So this is a very fine membrane, but this is what's going to give us access to the cataract. And then once we have that circular opening, then we'll just use fluid to free that cataract from that bag. So that way we can preserve the bag to support the intraocular lens we're going to place. You can see there now the lens is freely mobile. And then conventional cataract surgery does involve using ultrasound to remove the cataract from the eye. So you'll see that next. This is the ultrasound probe, and basically the cataract is broken into small pieces and removed from the eye. And then once that cataract is been removed, here just kind of finishing up removing some of the lining of the bag there. then we will place a intraocular lens here. You can see it's folded, so it goes through a very small incision and then it opens up in the eye. And this lens needs to be placed after the cataract's been taken out to help with focusing. And we're going to talk about the different lens options and then kind of bring in the different conditions and how it could impact if you're a candidate or not. So that's basically cataract surgery in a nutshell. And when it comes to those intraocular lenses, we have a standard monofocal lens, which is a very good lens. This gives one focus point without glasses. So it can be set for distance. So distance vision will be better, but then things like computer screen and reading, patients will require glasses. It could be flipped where it's set for reading, but then for things far away, patients need glasses. Or if a patient's done well with monovision, that could be an option. But once again, this is not going to get patients away from needing glasses, but quality of vision will improve. Other lens options are, we refer to them as lifestyle lenses. So these are really more for people that are trying to become independent from needing glasses. So for example, a multifocal, which the more common recent multifocals are trifocals. This lens gives three different focus points, so one at distance, one at computer, and another for reading. That can help patients get out of their dependence of needing glasses. However, there are conditions like glaucoma or things that affect the macula or the retina, or even the cornea, where a patient may not be a good candidate for that. There's an extended depth of focus lens. This is a lens which takes a focal point and then kind of extends it so a patient could have distance vision with a range up to kind of intermediate or computer screen. We also have a light adjustable lens. This is a lens that basically after the surgery, we can use UV light to adjust the focal point. So this is a great lens option for someone who is really wanting to get a specific focal range. So we can kind of tailor it to where their focal point is, or someone that's had a previous corneal surgery like LASIK or RK to kind of get that lens and their focal point to where they want and customize to their cornea. And then lastly, we have an astigmatism correcting lens because our monofocal lens, which is a lens that's covered by insurance, does not treat astigmatism. Many people have astigmatism that is in regards to the shape of their cornea. That lens can help treat that as well. And just very briefly, just kind of showing what this means, putting it like in an example. So this is kind of normal, healthy vision, having distance, intermediate, and computer. As we get older, we lose the ability to see up close. You can see the cell phone is getting blurry. As we continue to mature, then we develop a cataract that affects the overall color and contrast and ability to see. Cataract surgery with a monofocal lens, you can see with this lens, really good distance vision. Things intermediate and up close are blurry. And then next, as we progress here, this is basically a multifocal lens where, multifocal lens where you have distance, intermediate, and up close. So just trying to show that with the monofocal lens, that single focus lens, low incidence of glare and halos, for example, at night. With a multifocal, about 10 to 15% of patients will see a little bit of a halo around lights, specifically at night. So another kind of consideration if you're wanting to get out of glasses, that would be something that does occasionally happen. Laser cataract surgery is another option. This is where we use a laser to assist with parts of the surgery. This is also not covered by insurance, so it's an out-of-pocket, but the laser basically helps with different portions of the surgery, specifically with making the opening to the cataract, and then helping soften the cataract before we started the surgery, the ability to kind of make incisions in the cornea to treat astigmatism, and then lastly, make the incision so we don't have to use blades. And just to kind of show you a real life example on the top left here, these are the openings to the cataract made by the laser versus the bottom right when it's made by hand. Although it does look circular when it's made by hand, you don't have that precision and that circular kind of consistency when you do it with the laser. So just kind of highlighting why some people consider laser cataract surgery. All right, so that was kind of our intro to cataracts. And I'm going to try to get through the next slides so that my partners can have enough time for their part. And we will take a few questions if they're in reference to the corneal portion of the presentation. So probably we'll open it up for 3 questions and then move on, and then try our best to hit any remaining questions at the end. I would ask for questions if we could try not to have any questions specifically about like personal like health questions. Just it's really difficult if we don't have your full history. So for those, I would recommend just coming in. But if it's in regards to any of the conditions or anything we discussed in the slides, I think it'd be perfect that we address those this evening. So when it comes to ocular surface considerations and cornea, when it comes to cataract surgery, the most common is dry eye. And dry eye is actually one of the most common eye diseases in the United States. 38 million people suffer from this condition, so that's 1 in 7 Americans. And so that on its own is a separate topic, but it does affect cataract surgery. And, in general, the most common presentation to the eye clinic is dry eye. Surgical procedures, whether it's LASIK or even cataract surgery, dryness does get worse after, and we know this. And so this is something that we want to pick up beforehand, treat, optimize for cataract surgery and other surgical procedures, not only because we know it's going to get worse, but it can affect our pre-op measurements. And then, dry eye after cataract surgery is common for the most part. Starting treatment can take care of it and it's under control. The other thing is dry eye, the incidence is continuing to increase because we have so many risk factors that we're all kind of exposed to, whether it's computer screen, getting older, our gender, health conditions, medications. And so there's so many things that play a role in dry eye. And very kind of briefly, what is dry eye? It's basically loss of the normal tear film homeostasis. And so our tear film is made up of an inner mucus part, middle watery part, and an outer lipid or oily part. So anything that affects any of those layers leads to dry eye. Many people think dry eye, it's no big deal. But here on the left, you can see this is a patient's cornea. And this is what I'm looking at when I examine them. I place a dye and I use a special filter light to look at that dye to see it. And you can see very quickly within a few seconds, we're getting dry spots in the cornea. And about 2/3 of the focusing of the eye happens where the tear film and the cornea meet. So this is really visually significant. And just trying to give you a real life example, that's like if you were trying to drive a car with a dirty windshield, it would be very difficult. In addition, this affects our measurements when it comes to determining that lens power that we're going to place in the eye that's going to stay with the patient for the rest of their lives. So we want to make sure this is optimized. And so, very briefly, there are many different treatments, and within the last few years, we've had more customized treatments where we can target specific causes for dry eye. So, it's very important to not only know that you have dry eye, but what type and understanding what type of dry eye you have so we can initiate the right type of treatment. So, this as well, if you're interested in this, I would recommend joining the seminar we have just on dry eye, where we'll go more in depth into this. And so, kind of tying this to cataract surgery, um, our measurements are very important, and we are measuring that surface of the cornea when it comes to the lens that's going to be placed in the eye. So if someone's eye is dry, it's going to affect those measurements. If we have bad measurements, our lens estimation is not going to be accurate, and so it can affect post-op vision. So one of the major reasons why we need to address this. Also, we know with surgery, the post-op drops, the dryness will get worse. So again, we want to optimize beforehand for those two reasons, so that way we have great outcomes, and then also our patients are happy after surgery. Just kind of sharing the literature out there. 60% of routine cataract patients had dry eye, but they were asymptomatic. And half of them who presented for a cataract evaluation had actual signs of chronic dry eye. And then, those specifically coming in for surgery, 80% were found to have dry eye. And so, once again, this is very common. And in many, many situations, the dry eye there is present, and it just gets worse after surgery. So again, just kind of sharing the literature of why it's important that we're screening and treating for this. So moving on to the next corneal condition, LASIK and PRK are two different laser treatments that we have to treat either nearsightedness or farsightedness. So people before they have cataracts and want to get out of glasses, they can have LASIK or PRK. With the laser, in both of these procedures, we are either flattening the center of the cornea or steepening the center of the cornea. And so when it comes time for cataract surgery, the cornea is not the same shape in the center versus the peripheral part. Again, very important when it comes to getting our measurements for the proper lens to be placed in the eye. So this is something we definitely want to have really good measurements for. So obviously make sure the dry eye is optimized, and then also our pre-op measurements be done correctly. When we talked about the different lenses, this is where that light adjustable lens is a great option for patients who've had LASIK or PRK, because the cornea has those subtle aberrations. We can actually, with the adjustments after the surgery, get this lens more customized to that patient's vision needs. So just in addition to someone wanting spot on vision where they want it, someone who's had LASIK or PRK would be a great candidate for having a light adjustable lens. On the same spectrum, but something called radial keratotomy. This was a procedure done in the 1980s to 1990s before we had the laser, where small incisions were made in the cornea to cause the cornea to be steeper to treat nearsightedness. And so, early on, this was the only treatment we had. And then when the laser came on, this kind of stopped being done. But there are many patients that had this done and now need cataract surgery. And so same kind of a thing as the prior vision correction with LASIK or PRK. The center of the cornea is different than the peripheral part of the cornea. And so our pre-op measurements are important using things like intraoperative aberrometry, where we are able to do measurements on the table during the cataract surgery to, again, check the lens power based on the patient's cornea is very helpful. And also with RK patients, the light adjustable is another great option. A few more conditions here before I pass it on. There is a very common condition, about 10% of the population has it. It's called epithelial basement membrane dystrophy or anterior basement membrane dystrophy. It's a very subtle condition, and I'd say 90% of patients who have this never even know and don't have any symptoms. But basically, the epithelial cells, the lining of the cornea in some areas are a little bit more elevated than others. And so these patients, if their dry eye gets worse, they're prone to having corneal erosion. If these kind of deposits are in the central vision, you can see on this photo on the right, these kind of little elevations, almost like these little map lines, they create irregular astigmatism that can not only affect our measurements when it comes time for cataract surgery, but also affect the patient's quality of vision. And so in this kind of a condition where it is affecting the central vision and there's irregular astigmatism, we have a procedure we can do prior to surgery called a superficial keratectomy. So here on the left, just showing you, this is a corneal map of a patient who had anterior basement membrane dystrophy. And you can see here their central cornea. Basically, the lighter color here just shows more irregularity and elevation, which is in their central vision. And they were measuring just under maybe like 0.71 diopters of astigmatism. They had a superficial keratectomy, which is a procedure we do in clinic where we remove these irregular cells and then allow a new sheet of epithelial cells to kind of grow. We get a little more regular measurement here, and their astigmatism went down by almost 5 point or half a diopter. So this would definitely cause a big shift and difference in the lens measurements when it came to this patient. So just trying to highlight why that's important to have this detected and taken care of before cataract surgery. Another common condition is Fuchs corneal dystrophy. This is a condition that affects the back layer of the cornea, that clear part of the cornea. We get these little deposits that form. It looks like a beaten bronze kind of appearance. And so these deposits themselves can cause glare in addition to the cataract, but also they affect the pump cell function of the cornea. Those pump cells are what's keeping the cornea dehydrated and clear. So if those pump cells aren't working, the cornea can swell and it can affect our vision. Here on the right, these are specular photographs of a patient's cornea. On the right side, this is a normal cornea. You can see all the pump cells. These hexagonal cells are pretty similar in size. Here on the left, we have a patient with Fuchs with these deposits. And so where this comes into play with cataract surgery is someone with Fuchs, their cornea may not be able to handle the cataract surgery. And so their cornea may become overwhelmed and decompensate and be swollen. And so basically their vision could potentially get worse after the surgery. And in those cases, we have a partial corneal transplant procedure that we can do at the same time as cataract surgery to take care of both these conditions at the same time, also saving our patients from having to go through two separate surgeries spaced out by time. And very briefly, just kind of showing you, this is a surgical video of that partial corneal transplant. So from inside the eye, here I'm removing those abnormal cells from the back of the cornea through a small microscopic incision. And then once those disease cells are out, I basically take a layer of pump cells from someone's cornea who's donated it or passed away. And then that is what is basically, here you can see it's injected through an injector into the eye. It's a very thin layer of those pump cells. And here it's kind of scrolled up to get through that small incision. So just basically injecting that into the eye. And then after that, it's a gentle tapping to get that tissue to unravel and go into place. And then a gas bubble is placed underneath to help those pump cells start to stick. And then our positions lie flat for about 2 to 4 days. And then after that, the pump cells usually are sticking and start clearing the cornea. So just showing you this is a surgical technique we can do at the same time as cataract surgery. You can see now we've kind of tapped out those pump cells and they're in the correct orientation. We can see this S stamp that shows us that the tissue is not upside down. It's in the right orientation. And then we place that gas bubble underneath, which will go away over a course of a week or two. Um, Pterygium, this is another common condition we see here in Southern California in relation to UV light and dryness and kind of genetics. This is another condition you can see here that can affect the overall surface of the cornea when it comes to cataract surgery. Very important that we normalize that. So our measurements are improved. So we basically remove this and then take a graft from another part of the white of the eye to cover that. And then we could proceed with cataract surgery after. Keratoconus, another condition with irregular astigmatism that can play when it comes time for cataract surgery. So important that this is screened for and properly treated. We have a procedure where we can stabilize this if it is progressing. And then lastly, there is a condition called Salzmann's nodule degeneration. So this is where the cornea starts building these fibrin nodules to protect itself from chronic inflammation. And these little bluish white nodules on the cornea can cause irregular astigmatism. You can see here on this topography elevation map of the cornea. Similar to the anterior basement membrane dystrophy, this is something that we want to remove and allow the cornea to stabilize before we proceed with measurements and proceeding with cataract surgery. So that was kind of a whirlwind through ocular surface diseases and cornea when it comes to cataract surgery. But our ultimate goal here is to optimize ocular surface diseases to improve our surgical outcomes. And our last thing is that we don't want to do is make our asymptomatic dry eye patients who are pre-op into symptomatic patients post-op. So really taking the effort to diagnose and treat dry eye appropriately. Thank you guys so much. With that, I'm going to pass it on to Dr. Smith.
Okay, thank you so much, Dr. Bashad, and for that really good introduction. My name is Andrew Smith. I am an assistant professor at the Gavin Herbert Eye Institute, and I'm a glaucoma specialist. And so I'm going to try to build on what Dr. Bashad shared by kind of sharing the insights of cataract surgery from a glaucoma perspective. And so in order to understand those insights, we first have to cover what glaucoma is. So this is a picture of the back part of the eye. This yellow dot over here is the optic nerve, and glaucoma is when this optic nerve starts to slowly degenerate over time. And that degeneration is highly associated with eye pressure. So the pressure usually we measure is in the front part of the eye, and the back part of the eye is what is affected. So this is a good transition kind of from the front and back part of the eye here. What happens to the optic nerve is it slowly loses all of its fibers. So if you look at the left part of your screen here, this optic nerve has 1.2-ish million fibers that are coming through it. And if you have glaucoma, those will slowly die. And what happens to the optic nerve is it changes its shape. We call it cupping, where it kind of bows back. So this in the center is kind of like a moderate, and this on the right is like an advanced glaucoma, where the optic nerve fibers have slowly degenerated. And what does that look like, or how does that affect someone's vision? It affects mostly their peripheral vision with some exceptions. So in the top left hand corner here, you have a full visual field. In the top right, you have a visual field that's slightly affected on the sides. And then bottom left, more affected, and to the right is kind of end stage glaucoma. I share this slide not to look at all the names here, but just to recognize that glaucoma is a very expansive field, and there are a lot of diseases that are associated with glaucoma and a lot of different types of glaucoma. So it's very complicated, and obviously don't have time to get into that in this lecture. But the next question is, how are cataracts and glaucoma related? Well, just like Dr. Bashad was sharing, here are some pictures of cataracts. But what I want you to notice in this picture is if you look at this top right picture, you have a blue iris, and right behind the blue iris is the cataract. So the iris and the cataract are in very close proximity to each other. I'm going to show you a schematic of the eye now. And this is the cornea that Dr. Bashad was covering. This is the white space in between the cornea and the iris. This red structure here represents the iris, and the yellow is the lens. So it turns out that the drain of the eye is in this corner over here between where the iris inserts into the side of the eye and where the cornea kind of meets the sclera. And we call that structure the angle. And the first structure, the first layer of the drainage system, we call the trabecular meshwork. So this schematic is showing that the fluid is produced in the eye right in front of the lens. It flows behind the iris through the pupil and then around and into this angle and then drains out. And if there's any problem with this angle, then the pressure is going to come up and we'll develop glaucoma. In cataract surgery, as Dr. Bashad showed in that great video, our instruments are operating in this white space right here, or a little below it, like right at the iris plane. And so during cataract surgery, if you have glaucoma, it makes sense to just reach over here into the angle and maybe perform an additional procedure, which we'll cover later, in order to help treat the glaucoma. Another way cataract surgery affects the glaucoma is the lens itself in relation to the drainage system. So this picture is showing a lens that's moved forward. And because it's in such close proximity to the iris, if the lens moves forward, the iris will bow forward. And this structure, which was once open, is now closed. And we call that closed angle glaucoma. There's a whole group of glaucomas that are caused by closed angles. This can happen like this picture is showing from the lens moving forward, or as you age, your lens grows over time. And that growth of the lens can push the iris forward, and something similar can happen here. So cataract surgery, if you take out the cataract, the iris will relax back. So if you look at this picture, the lens has a certain thickness to it. Once you take it out and put in one of those intraocular lenses that Dr. Bashad was showing, it's much thinner. And because it's much thinner, it won't exert as much pressure on the iris. The iris will fall back and the drainage system will open. So this is one of the reasons why cataract surgery alone usually reduces the pressure by 2 or 3 points. And it's why cataract surgery is considered also a glaucoma procedure. So I want to talk about pairing glaucoma and cataract surgery. Really quick, let me talk about the treatment. The treatment of glaucoma revolves around decreasing the eye pressure. And basically, we divide the treatments into what we can do in clinic and what we can do in surgery. So really quick in clinic, we can manage eye drops and we can do these little laser procedures that help with the flow of the eye. This is not part of the scope of this lecture. We're going to focus on the surgery side. The surgery side, I group the procedures into 2 major headings. One surgery is basically trying to enhance that normal natural drainage system that you have. And there are 4 kind of different aspects to doing that. And the second category of surgery is just giving you a new drainage system. So a good analogy might be like looking at a sink. You know, if you're enhancing your normal drainage system, you might just try to widen the drainage hole of a sink or stick down a little catheter down the pipes and trying to get them to enlarge and work a little bit better. But there are glaucomas that are severe enough where you just have to get a whole new sink, basically. And those are the bottom 2 here. I'm showing the bottom 2 procedures here are one of them. So this are tube shunts. This little tube goes on top of the eye between the muscles you can see here, and you run the tube into the front part of the eye where all the fluid is, and the tube shunts the fluid to the back part of the eye. So this is like giving someone a new sink. This can be paired with cataract surgery, but often it's not. Often it's staged into 2 different procedures. What we want to spend more of our time talking about is the first category, enhancing the natural drainage system. These procedures have been termed minimally invasive glaucoma surgery, or MIGS. It's kind of a marketing term. It doesn't really precisely say what is actually going on in the eye, but it's kind of a way to say we can do these small procedures during cataract surgery to enhance the drainage system. These procedures were actually invented, the first 2 of these were invented at UCI, and so we are heirs of UCI's innovation, which we're so fortunate to be. But once they were invented, like in the early 2000s, a lot of companies put a lot of effort to make a bunch of different devices that basically do 1 or 2 of these functions. And so a good thing to know if you're a glaucoma patient is you might have friends who have had cataract and glaucoma surgery, and they might say they've had a surgery and might name one of the devices. So for example, they might name the Kahoot dual blade or the Omni or the Hydrus and say, I had that procedure. And really what they're saying is that's the device that was used to perform one of these MIGS procedures that we perform, which is basically enhancing the normal drainage system. And so this is basically repeating that. I really just wanted to highlight here that the UCI, really pioneered these and these procedures. There are 4 of us here at Glaucoma. One of them was the one doing the research and all the trials on one of these devices, and so we're so lucky to have her and to learn from her. But UCI has been a pioneer in this field. So I want to show you a video of one of these procedures being done. So the schematic I kind of pulled forward, and you can see it on the right-hand side of your screen. The instruments are in this white space in the eye, and then here is the angle, and then the red part is the iris. Over here on the video, you can see that the instrument is just about to enter the eye. This is the same incision that would be used for cataract surgery. And you'll see as this instrument is entered into the eye that the iris kind of blows up there. I'm going to pause the video here. If you look at the video here, the instrument is in the eye. There's a lens on top of the eye, and this lens allows us to see into the drainage system. And it's very faint, but this gray line across here is the drainage system of the eye, the trabecular meshwork, the very initial step. And so what we're going to do here is just remove the trabecular meshwork to open it. So as this knife goes across the trabecular meshwork, what you'll see behind the knife is a bright white line. And that bright white line is the exposure of the inner workings of the drainage system. And that's going to decrease the resistance of flow so that things will flow more easily out of the eye and decrease the pressure. Okay, we're going to move on here. The next thing that MIGs also do is, besides just removing that trabecular meshwork, they can help to open the drainage system further. So this is the second schematic of the eye where that iris was pushed forward. So after you've removed the lens, a lot of us will stick these instruments into the angle and just push this iris back down so the angle can open up again. So that's what you're going to see in this video. That lens is going to go on the eye. That same view is being shown here, but you can't see that trabecular meshwork. The instrument is being used to push the iris back very gently. And as you can see, that kind of dark brown line that's coming into focus, that is the drainage system that's being exposed. And so doing cataract surgery helps to relax things, but you can remove any scar tissue that might develop and help get the drainage system flowing and get the pressure down that way. Okay, I'm going to close with some other considerations for glaucoma patients having cataract surgery. And I saw that one person asked about pseudoexfoliation. I'll try to mention pseudoexfoliation here a few times to answer that question. So glaucoma patients, unfortunately, just have higher complications during cataract surgery. That happens during surgery and after surgery. Poor pupillar dilation, this is something that pseudoexfoliation often has, by the way, but glaucoma people in general have poor pupillar dilation, and that makes the surgery a little bit more difficult. Zonular weakness, the lens that we have is supported by a bunch of trampoline springs. Like picture a trampoline in the middle of your eye and the springs attaching to the side of the wall. And those zonules are those little springs. And pseudoexfoliation again, but also just in glaucoma in general, those can be very weak. And that can make the surgery more difficult. Things are wobbling around. And sometimes the lens is not as supported in the center of the eye. You can have a rupture of the capsule. That's where the lens is supposed to go. That's higher rates in glaucoma. The cornea is at more risk of being damaged and needing more procedures. And then after the surgery, the pressure of the eye can spike, so it can be too high after the surgery for a little while. The pressure of the eye can be too low. Sometimes things overfiltrate actually after glaucoma surgery, and that can cause other problems. Dr. Mishra is going to talk about retinal swelling, but that is more common in glaucoma patients as well after surgery, as well as just general prolonged inflammation. Sometimes you need to use the drops for longer than a typical course. And then lastly, refractive surprise is more common in glaucoma. This means that you did those measurements that Dr. Bashad was talking about. You put them into a math formula. You got the lens that you think is right, and you put it in the eye, and it turns out it's a little bit off. The formula doesn't quite match exactly what you want it to. And so that is more common in glaucoma as well. The second consideration for patients with glaucoma is the type of intraocular lens. We really prefer doing monofocal lenses if possible. Toric lenses is technically a type of monofocal lens because it has one focus point. Although you can introduce toricity into multifocal lenses, which we'll talk about after this. But a toric monofocal lens would be okay. That usually means that the vision is going to be optimized at one distance, like was talked about, but you'll definitely need reading glasses for another distance. Most people choose to be focused in the distance, so this car you can see when you're driving, but up close, if you're looking at the dashboard or your phone, it's going to be a little bit blurry unless you have a pair of reading glasses. And then of note, those light adjustable lenses where you can adjust the lens, they're okay to use as far as the lens goes. It is a little bit more difficult to do the adjustments if something happens with glaucoma, with the glaucoma portion of the surgery, if you choose to do that, or just with glaucoma in general. So that should be considered, but it is okay to use those lenses. The lenses that we try to avoid are the multifocal lenses and the extended depth of focus lenses, which are unfortunately the lenses that give you more of the range of vision and try to create some glasses independence. And the reason we don't like those is because they do decrease contrast sensitivity a little bit. And glaucoma, when the optic nerve gets damaged, you already have a loss in contrast sensitivity. And we do not like those two hits to the contrast sensitivity for the eye. So most glaucoma specialists will advise patients to avoid these types of lenses in order to make the vision better, like the monofocals will do. Okay, in summary, a cataract surgery and glaucoma, it's a surgical opportunity to address two issues in one session because you're already in the eye. You can use the same incisions. Doesn't add too much time. The additional risk is not too much. If you have glaucoma, you should consider a minimally invasive glaucoma surgery, which is basically enhancing the normal drainage system at the same time. However, you should recognize that complication rates are higher with glaucoma patients, and you want to go with a surgeon who you trust and who you can talk to and communicate if something happens, and make sure they get you to a good spot. And then the last thing is you want to consider your lens choice and make sure you're optimizing your vision and not prioritizing glasses independence over, getting the best vision possible. A little plug at the end here for the glaucoma division at UCI. I am humbled to be part of an amazing department of glaucoma surgeons that are highly skilled at complex cataract surgery. Like I said, these minimally invasive glaucoma surgeries, which are basically ubiquitous at this stage, were invented here at UCI and really pioneered here. And like I said, we're heirs of that innovation and have trained there. We also do other surgical clinical trials. We've done multiple research projects, including some on herbal medicine. The first randomized controlled trial about marijuana and glaucoma was done at UCI. And we're nationally renowned fellowship training program, and we're really proud of that. And there's four of us here. I'm the least among us. I think I admire all my colleagues so much, as well as Dr. Bashada and Dr. Mishra, who you'll hear from here shortly. And that's all I have. So thank you so much for the opportunity to present and to chat with you. Okay, with that, I'll turn the time over to Dr. Mishra so we keep the time going, and we'll go from there.
Awesome. Thanks so much, Dr. Smith, Dr. Bashad, for those wonderful lectures. I'm Gavin Mishra. I'm a retina specialist and ocular oncologist here at UC Irvine, and I have the pleasure of kind of finishing up our evening today with retinal considerations in cataract surgery. So this is important because Dr. Bashad and Dr. Smith so nicely discussed cataract surgery. And, I want to step back and say it really is one of the safest and most performed surgeries in the country and what we have in medicine. And obviously the eye is a complex organ, and we want to make sure that we're doing the most appropriate types of surgeries and the types of lenses that we can offer for patients. And just like you can have glaucoma issues, cornea issues, you can still have retina issues and also have a cataract. And so there are certain conditions or considerations that we have when you have multiple things going on at the same time. There are a lot of lens choices that the cataract surgeons will discuss with you, and they may offer you certain choices that a friend of yours or a family member of yours did not have the opportunity to have, or vice versa, where they were offered a lens choice that may not necessarily be appropriate for you. And that really is because there are not only so many options, but every eye is different. And so we were kind of discussing a little bit in the chat that really it's a personalized decision with your surgeon on what's the best for you. And finally, I'll say that it's not necessarily a soulmate of a lens option in that you may be happy with a few different types of lenses. And so I wouldn't overstress kind of picking the exact right one. And that, there are a couple of different lens options that can work. And so we'll kind of get into that a little bit. And so let's just kind of step back and talk a little bit about eye anatomy. Dr. Bashad and Dr. Smith spoke so eloquently about the front part of the eye and glaucoma as well. The retina is the wallpaper in the back part of the eye, and we kind of think of it as like the film in the camera. And if you think of light entering the eye from the front and then going through the cornea, the front part of the eye, and then the lens, and then hitting the back, you really need a very clear sort of pathway for the light to enter. So when we're examining you, if we can't see so clearly into your eye, then it makes sense that you may not be able to see as well looking out of the eye. And regardless of how good or how amazing the cataract surgery goes or how good the front of your eye looks, the best camera lens in the world won't help if the film, which is the retina, is damaged. And so some of these conditions, we've come a long way in treating retinal conditions, but we have to make sure that we're treating it appropriately before cataract surgery. And so there are some intraocular lens options. Dr. Bashad and Dr. Smith touched on this, that they're monofocal standard lenses that really have one focus point, and most people pick for distance, but you can pick it for near vision as well. We usually consider these to be the best for patients in which they have some serious retinal conditions going on, or conditions in which their retina is affecting their vision. There are other lenses that are multifocal or extended depth of focus. Many of these lenses are not covered by insurance, and they are wonderful lenses as well. But in some ways, because they have multiple focus points, that can reduce the contrast sensitivity and cause some imaging artifacts, which may be more troublesome or more bothersome for patients with retinal conditions. And so these aren't necessarily for everyone, but there are retina conditions in which it's okay to undergo surgery with a multifocal lens. Toric lenses correct for astigmatism, and these can be in the setting of a monofocal or a multifocal, and these are excellent lenses. And these can, for the most part, be pretty much used for any eye, which we'll also get into. So I wanted to discuss some retinal conditions. The most common one is age-related macular degeneration. I'm sure everyone on the Zoom call may know someone, either a loved one or a friend, or you yourself may have age-related macular degeneration. It's the most common cause of vision loss in people over the age of 50. That's irreversible in some cases. It affects the macula, which is the center part of the retina. And there are different stages. Most people kind of know the difference between dry macular degeneration and wet macular degeneration. Wet was historically the condition in which we offered medication in the form of a procedure in the clinic. And we would do that by numbing up the eye and then giving an injection of the medication. But now with the advanced stages in dry macular degeneration, we also have treatment options for that. And this affects the vision most noticeably in the center. And so when you're undergoing cataract surgery for macular degeneration, we say that surgery is generally pretty safe, but we counsel the patient that when you have two conditions going on, something in the front of the eye being the cataract and then the retina being affected by macular degeneration, it may be hard at times to really give an exact weight to how much each condition is affecting your vision. So when we examine the retina and we see some changes to the macular degeneration, when you have cataract surgery, the vision may or may not improve significantly, and that really is due to the retina. If someone has wet macular degeneration and they're getting treated with the injections, then we like to make sure that the disease is very stable and that you don't require injections as frequently as once a month before undergoing cataract surgery, if we can help it. In some cases, the cataracts get so advanced that we have to do cataract surgery, even if you're getting frequent injections. In terms of lenses, monofocal tends to be preferred because it provides the clearest quality of vision and the light isn't split into multiple focus points. And so we tend to not put in multifocal lenses in patients who have intermediate or advanced macular degeneration. If you have dry, early macular degeneration and it looks very minimal, then it is reasonable on a case-by-case basis to undergo a multifocal lens. The reason is because macular degeneration affects the central vision, so we want to try and reduce the number of artifacts overall in terms of your vision. Diabetic retinopathy is the other condition that we see very commonly in the retina. Diabetes affects the blood vessels throughout the body, and there's several or many blood vessels in the back of the eye. And so when a patient has diabetes, we screen them for diabetic changes in the retina. And if we start to see changes, then we examine the patient more often. So without any changes, we usually do once a year. And then once we start to see changes, it could be once every 6 months or 4 months or 3 months. And in some stages, if new blood vessels grow that can bleed, or if there's swelling of the macula, we call that macular edema, then patients require treatment for that, and that can affect the central vision. And so when patients have diabetic retinopathy, we want to make sure that the diabetic retinopathy is controlled before undergoing cataract surgery, particularly if a patient has macular edema, because cataract surgery can worsen the macular edema. So we may have to provide some treatments of some sort, usually in the form of an eye injection, to make sure that a patient is stable before undergoing cataract surgery. In terms of lens recommendations, this is pretty similar to macular degeneration in that if a patient's central vision is affected by a retinal condition, then we tend to try and avoid a multifocal lens if there's uncontrolled macular edema or if the vision is clearly affected due to the retina, which is not reversible. High myopia is a very common condition. It really is an epidemic throughout the world. It's when you have severe nearsightedness, typically a -6 or stronger. And then in this image on the right hand of the screen, the normal eye, the light enters the eye and it hits the retina appropriately. When a patient is myopic, the light enters and hits in front of the retina. But when a patient is highly myopic, the eye is really stretched out and the light really hits the front part of the retina pretty significantly further in front. When the eye is stretched so much, the retina is actually stretched as well, and the retina becomes thinner. And there are side effects or conditions that can happen, including retinal tears, detachments, myopic macular degeneration, myopic traction maculopathy. And patients, when they're very myopic, they may develop cataracts at an earlier age than patients that don't have high myopia. And so when we consider cataract surgery for them, I reassure all patients that if you're very, very nearsighted, it's very important to get a preoperative examination, usually with the retina specialist, such as myself, but you're not doomed by any means to have a retinal detachment. The retinal detachment risk in a patient that is not highly myopic is very low. And with patients who are highly myopic, it does increase, but the overall absolute risk is still on the lower side. And we watch very closely in the first 3 to 6 months, and then up to a year is when that risk tends to be higher, and then that tapers off. In terms of lens recommendations, if you're highly myopic, but your retina looks totally fine in the center, then it's totally okay to go over all the lens options with your cataract surgeon. But if there are advanced retinal issues in the center, such as very advanced traction, a lot of bleeding that's happened in the past, then a monofocal lens may be more appropriate. Anytime you undergo cataract surgery, really with any of these conditions, and you start to see new floaters, which looks like a lot of bugs in your vision, or you start to see new flashing lights, or you see a missing part of your vision, like a curtain or shadow, make sure to call immediately. Uveitis, I'll just touch through pretty quickly. This is inflammation in the eye. 50% of the time we don't have a cause for it, but 50% of the time it could be from autoimmune disease, infectious. Sometimes it could be from malignancy or an injury that's unknown. It can affect all parts of the eye. And the point with uveitis is that we really want to make sure the eye has not had any active inflammation for at least 3 months, because if you were to undergo surgery, the eye does not like to have surgery in itself. And so that can increase inflammation and can make it very difficult to manage and can lead to complications. For retinal detachment, if a patient has had a history of a retinal detachment, it's it's totally fine to undergo cataract surgery, but there are some considerations. When we do a retinal detachment surgery, we could do it with surgery, we could do it with the scleral buckle, a vitrectomy, we can do it with laser. A patient may have silicone oil that we filled up the eye with, or a gas bubble, which goes away by itself. But the vast majority of patients, about 90% or plus of patients in the first 2 years after retinal detachment surgery require cataract surgery. And so I tell patients you're essentially bound to undergo cataract surgery, and likely at a much sooner stage than your other eye. And it is totally fine to undergo cataract surgery. There is a slightly increased risk of redetachment, and so we would follow you closely after you've had the cataract surgery. Sometimes if we put silicone oil in the eye, we can take that out at the time of cataract surgery as well. And so this is kind of for all of these conditions, every patient is different. Every patient has a different amount of their retinal condition, how severe their cataract is. And so this is why I love being at UCI, because we all work so closely together. We all share a medical record system. We all talk all the time about patients, about what's the best, and we kind of put our heads together to make sure that we're doing the absolute best for you that we would want for our own family members. So when you get surgery, at cataract surgery, and you have a retinal condition at the same time, you should be following with your retina specialist and your cataract surgeon, and so that we're all making sure that we're not seeing any complications that can happen with anyone. And so I also wanted to point out our retina division has some wonderful colleagues of mine, including the chairman of our institute, Dr. Cooperman, and then there's Dr. Brown, Dr. Liu, Dr. Mehta, and Dr. Riazi. That's such a wonderful team, and we're happy to see you at any time. And thanks for your time.